Welcome everyone to today's webinar, Building an Ambulatory Strategy and Plan to Lead Your Organization to Success. I'm Mackenzie Bean with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. We will also have a polling question during today's webinar. When we reach the poll slide, the poll question will pop up automatically on your screen. Our speakers will give a few seconds for you to select an answer from the options on your screen and click Submit. Thank you in advance for your participation. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Wes Rickers is the National Director of Operational Improvement for IBM Watson Health. Wes specializes in hospital operations, finance, and revenue cycle. Currently, he is leveraging his expertise as a healthcare consultant, analyst, and solution architect to help prepare our industry for the transition to value-based care by trying to drive additional value from the incredible volume of healthcare data available today. Stacy Duke is the National Director of Operational Improvement for IBM Watson Health. Ms. Duke has been active in the healthcare industry for more than 25 years. Throughout her tenure at IBM Watson Health, she has worked with over 100 healthcare facilities and large national health systems, coaching executive team members in the strategic use of operational benchmarking, clinical benchmarking, marketing and planning, and productivity monitoring tools for organizational performance improvement. Jim Holohan is an associate partner on the IBM Watson Health Provider Consulting and Analytics team. His earlier experience includes executive leadership of a publicly traded healthcare provider, CEO of a specialty hospital, and CEO of a for-profit healthcare provider. Jim's current work centers on strategy development, population health, alternative payment models, and ambulatory and post-acute network strategies. At this time, I am pleased to turn the floor over to Wes to begin today's presentation.
Good morning. Thank you for that. Again, this is Wes Rickers, and I want to thank you all first. Good morning to some and good afternoon for others for joining us today. We're excited about the presentation, and we have a large number of attendees, so certainly this is a hot topic for the industry. So helpful to have a number of folks on, and we're looking forward to moving forward. Please use the Q&A as we go through the process today, and we'll address those here at the end of the presentation. So today we're going to focus on the ambulatory strategy and the ambulatory part of healthcare. We've focused on the four walls, the inpatient part of healthcare for so long now. Really, the challenge is we haven't made enough progress. And so if we're going to make a fundamental impact on our industry, the way we deliver care and the value we deliver to our communities we serve, we need to rethink not just how, but also where we're delivering care. Let's take length of stay for an example. Length of stay is a common focus for organizations looking to decrease cost and improve the patient experience within the inpatient setting. How do I get patients out of the hospital quicker, right? That's one of the key things we're seeing. And we've seen a trend toward, hey, how can I decrease my overall length of stay, assuming that you can have the impact on cost? But in reality, we recently conducted a study in which decreasing lengths of stay, with the exception of within the ED, had really no impact or marginal impact on cost. And that's because when care is provided for a shorter length of stay, it often requires quicker labs that turn around and that tend to cost more money. You may have more staff on hand to provide more services and get the patient turned around more quickly. What we need to do is rethink the way we're delivering care. And we've seen this with a lot of organizations where these services that tend to take 3 days, so think hips, knees, breasts, those services tend to have the patient sitting in that bed, the inpatient bed for the first day, waiting for service to happen. The second day, the procedure happens. And the third day, they're waiting for discharge. And so we've seen a lot of hospitals shift that service from an inpatient to an outpatient setting where you're in and out in one day. And that has an impact on the overall cost delivered to the patients that we serve. It has an impact on their experience, and as we'll learn in a little bit, has an impact on the overall quality of the care that's delivered. So, and it's not just the less expensive nature of delivering care in the ambulatory setting. It's really thinking about some of the challenges of being within the hospital, and Stacey will mention some of the impacts of hospital-acquired conditions and the challenges of staying in the inpatient arena. So in addition to some of those challenges we've seen historically, the trends are that we're going to see a higher increase or greater increase in the ambulatory setting than the inpatient. Over the next decade, the inpatient discharges are expected to increase by slightly more than 2%. Whereas in the outpatient, procedures are expected to increase by more than 15%. And so the purpose of today's session is to provide you all with some direction and focus as to your ambulatory strategy and how that might evolve. We've boiled down all of these various components we need to focus in on, and we've been able to focus in on 4 key areas that we want to help you gain some focus and direction within your ambulatory strategy. But before we do that, I want to spend a little bit of time discussing some of the challenges that we're facing within our healthcare system today. So providers like you in healthcare have never been under more pressure to deliver value, so high quality, low cost care in the market than ever before. And that pressure is coming from all angles. It's coming from payers who are increasingly who are increasingly putting out value-based contracts. In fact, about 29% of our contracts out there today are part of the alternative payment models. We're getting pressure from patients who are seeing these alternative payment models and high deductible health plans hit their wallet. And in the last decade, they've seen their deductibles triple. That tripling of the deductibles, the impact on their wallet, is leading to not only greater competition, but it's a focus on new competition, retail. So 88% of patients responding said they would seek care in a retail environment. And it's coming from our physicians, who end up getting the short end of the stick in a lot of these scenarios we've been coming across. And some studies show that physicians are spending as much as 86 minutes an evening or a night hunting and pecking the EMR, pajama time we call it. So doing work at home, entering data into the EMR. And so that's a really difficult challenge we've seen within healthcare. So how do you succeed? How do you actually provide value in a world in which you have so much pressure coming from all angles? Well, if you're like most providers in the country, you probably put some money into investing in your facilities, improving the cafeteria food, your weight rooms, your operating rooms, to really think about what is the experience my patients have. You're installing the newest equipment, the Da Vinci's, the new CT scanners, everything you can think of to improve the equipment and the technology you have to work with. And that technology is not just functional or hardware, it's also software. So point solutions across your organization to think about how do you connect various patient data elements from system to system. And then you've also probably thought about, how do I improve my processes? So instituting lean processes or Lean Six Sigma type processes to improve the overall efficiency and value of care delivered. And while these are important steps, this medical arms race we're embarking on may not actually get us to the point of delivering higher value. And the reason for that is simple, and that is that each of these touch points, each of these technology systems, each of these processes introduces new data sets and new data into the system, and those data systems need to talk. And so you have these connections that go back and forth from system to facility to equipment, and it makes this a very complex environment. And then if you think outside of that, it's not just what exists within those 4 walls of the health system, but you have data outside of the health system in the ambulatory area. Most studies show that the EMR holds only about 10 to 20% of the patient data we need to effectively deliver care to our populations. We love EMRs, they're great. They have their purpose, they have their need. Understanding how do you capture all of the data outside of this system becomes important, because as we increase the number of data points outside of the 4 walls of the health system, that increases the complexity of the environment in which we operate. The increased complexity within healthcare increases variability, and within healthcare, increased variability decreases value. So if we want to rethink the process around how do we improve the value we're delivering to our market, we need to refocus on that patient. We need to think about that patient not as a consumer, not as a particular acute care encounter. We need to think about that patient and the continuum of care across the entire healthcare network. Now, and not just the patient, but we need to also think about how do we capture the data associated with that patient so we can increase the insights that we can derive from that patient's care. We need to connect the patient with care providers, both inside and outside the hospital. And so in doing so, increase the decision-making process and increase the effectiveness of our decisions in delivering care to patients. And then ultimately, we need to do this at speed, and we need to do it with scale. These challenges, if we can approach this in this way, we can then begin to deliver on that concept of value to the patients we care for. So that's a little bit about what we've seen historically. Now, as we think about the ambulatory care setting, some of the complexity that we reviewed in the inpatient business is now being transferred to the outpatient, and that has some serious factors associated with it. Let me pause here and say that healthcare will never be simple. It will never be straightforward. Patients are complex beings. We are complex beings, and so we're going to have a complex system to support that. So again, we want to think about how do we focus in and understand the pressures and also the areas of focus we need to have to be successful. So first on this page, the complexity of the ambulatory setting, much of it has been driven by the consumer expectations in the upper left-hand corner of that circle. Consumers and consumerism, we've been talking about healthcare now for a number of years. And I remember when we first said consumerism or consumers, everyone had a big breath and said, no, they're patients, but truly they are both. They're consumers and they're patients. And I'd argue that the trend of consumerism in healthcare isn't driven, in fact, by Amazon, as we like to think. It's, in fact, driven by the high-deductible health plans that are putting a greater percentage of cost on the patient's shoulders or on their wallet. And so as a result, that cost pressure is leading them to be more engaged and seek areas where they can have lower cost care. And then we have the risk contracts in the bottom left-hand corner where these lower cost care settings become really complex to both administer and understand. We have a misalignment today, in most cases, of those contracts that are designed to deliver value but still incentivize for volumes. So clearly there's a challenge and an increasing challenge and complexity that exists around succeeding in delivering high quality ambulatory care. We haven't even talked about the right-hand side, thinking about physician burnout and the challenges of the EMR. And we hear so often that physicians who enter the industry to connect with their patients and have eye contact and deliver care, caring hands, healing hands to that patient, are now instead typing into the EMR while their back's turned to the patient. So understanding how do we connect all of those dots and become a successful, how to develop a successful strategy. In doing so, there are many questions that we come up with, and I think today we feel like we're left with more questions than answers. But at a high level, I'll start to boil these down into the kind of 4 key areas we want to focus in today. So the first is simply, where do I need to locate my services? What does my market demand? What will it tolerate? What might it look like in 3 to 5 years? Not just my market, but the providers in my market, the patients within my market. And I need to understand, where do I deploy my staff to accommodate the needs within my market? And am I going to do so to accommodate those patients in a fee-for-service world or a value-based care world where I need to really manage those patients in that population more acutely? And then once I'm there, once I've established myself in my market, where do I need to deliver care at a profit? In most cases, I want to say I want to deliver care at a profit with high quality, but it may also be that I need to identify markets, areas within my area, within my geographic location, that I am okay having a cost center, one where I'm actually losing money if it allows me to have a presence in a market that I need to grow into or that I'm seeing is going to grow in the future where I simply need a footprint. And then on the right-hand side, how do you leverage the technologies you have today, both through EHR and get to more real-time decision-making? And then also on the end, how do I think about empowering patients who I'm not seeing on a regular basis and engaging those patients to ensure that I have the ability to manage their care holistically? So now coming down to the 4 key areas, and we'll go through each of these individually. So the first thing we need to focus in on, I alluded to a moment ago, is how do I optimize my market strategy? Where am I? What types of services am I seeing? We know that patients are getting older. We know that patients are getting more acute. We assume that's going to lead to higher cardiac and orthopedic services. But what else might be going on in my market? Are there millennials moving in? Do I need to think about birthing centers and ways to attract not underinsured, but well-insured patients into my market? Once I have those, or once I understand that market, how do I manage my population? What percentage of that population do I understand? Am I touching on a regular basis? And what percentage are only seeing me when they're an acute patient and perhaps a chronic patient? So we'll look at ways to identify connecting with patients in the ambulatory setting, changing the quote-unquote front door of the healthcare system from what has traditionally been the ED to other settings of care. And then once we've done that, how do we deliver effective care? And effective care is two things. It's first, what are my outcomes? Am I producing the outcomes I would expect? Am I contributing positively to the overall health of my community? And then lastly, it's the no margin, no mission concept. If I can do all of these things effectively, I've got my market understood, I've got my resources deployed effectively, and my patients have positive outcomes. Well, if I can't do all of that with the margin, I won't keep my doors open for long, and therefore I won't be able to continue the care that we deliver. So focusing on these four elements are key components, we believe, to success within healthcare. I'm going to now flip over to a polling question. I'd like to get feedback from the group in terms of which of these four, for your organization, which of these four priorities is the highest priority for your organization. I'll give you about 10 to 15 seconds to enter your polls, and then we'll go to the result on the next page. Okay, let's go to the results. So when thinking about which initiatives are the highest priority for your organization, not surprising actually, we are seeing that managing costs and increasing efficiencies has taken the lead by 41.5%. These will change, and at the end of the session we can go back and see if anything has changed on these. But what's interesting on this is that a lot of our research and what we have been reading, research we've done and also have consumed, reflects this, that the big focus in healthcare today that we've seen is how do I decrease the costs. And what's surprising about this right now is that the focus in healthcare about cost containment, about decreasing costs, tends to correlate with a downturn in the economy. And what we're seeing right now is a booming economy, and also the other component we're seeing within managing costs is the word sustainable. So we have never seen more organizations focused on sustainable cost containment outside of a recession than ever before. So the feedback here is in line with what we're seeing in the market, and we'll go through these components and make sure we spend a fair amount of time on the managing costs and increasing efficiencies. And with that, I'm going to turn it over to my colleague Jim to dive into the optimizing market strategy and then managing patient populations. Jim?
Great. Thank you, Wes, and thank you to everyone for joining us today. We certainly appreciate your feedback on the poll that we're doing as well. So I'm going to walk you through optimizing market strategy as well as managing patient populations. When we look at market strategy, we know that the cost of building and operating is accelerating. You guys know that. You see that in each of your respective markets. Forecasting and locations must be precise. So from a forecasting standpoint, national rates that are adjusted for local populations, they're not going to cut it. They're flawed. What you really need is a market-specific utilization rate to allow you to get that local precision that reflects what's actually happening in your market. It's so imperative to get your planning portion of this correct, and that forecasting piece, getting that local precision is really imperative to allow you to invest with confidence and to avoid the cost of making a bad decision. As we look at planning and investing with confidence, you first need to start with assessing your competitive position. What is my current position in the ambulatory space? What future growth potential do I have? And that typically requires you taking a hard look at both your inpatient and outpatient utilization trends over the past couple of years, as well as assessing your competitor landscape, where are their locations and what offerings are they currently providing at each of those locations. The next piece is to plan your resources for growth, and that's where the location and the precision of the location really comes in. So whether you're a hospital or health system that is looking to add a new asset or new assets in the ambulatory space, or you're in a very competitive market and you want to find the optimal location to where to really plant your flag, or you have a fairly robust ambulatory portfolio right now and you're looking to really optimize your geographical footprint, the precision of the location is important. Just as important as what services am I going to offer at those locations. So going back to your competitive position and your future growth, what services or service lines look like they have the most opportunity for growth in your market? And importantly, what potential service lines or what potential procedures could you transition from an inpatient setting or an outpatient setting to an ambulatory care center? So It's a really critical thing to give thought to. And I think as we prepare for risk-based payments, many of you on this call are already involved in risk-based payments or are very close to getting involved. Having a comprehensive ambulatory care strategy is really an integral part of having a robust value-based care strategy. The two really go hand in hand here. And the key here, obviously, is really understanding your population, which is why the precision of the local forecasting is so important. But understanding the population and what maybe makes it unique from other markets in your area is a really key piece as we move into the next slide, that we know that outpatient services, the utilization of them vary greatly from market to market. So the disease prevalence, the lifestyle, the access to care are unique to your patient population. So we really want to, you starting with your county-specific rates and then multiplying that by some adjustments by zip code on some key demographic issues like age group, gender, and payer mix, just to name three, allows you to dig into a really market-specific local estimate. And the ability in these local estimates to be able to dig into the diagnostic category by the DRG really allows you to see what the potential is in the market. The goal here as you're going through the forecasting process is to eliminate market variation so that it really reflects what's going on in your respective market. All of that is really important to making a decision, at least a preliminary decision about what the landscape looks like, what the strategy looks like from an ambulatory care standpoint in your market. The next piece really revolves around managing your patient population. And our goal, as always, is to deliver the right care at the right time to the right patient. And I would say there should be a ... after that says at the right location as well. So starting to your left, really with the patient, is identification of the patients and re-engaging them with the physician and care team. We want to allow our physicians to get back to doing what they do best, which is providing care for patients. We also know that an engaged patient costs approximately 20% less to care for, and that sort of a staggering statistic to us is that 50% of patients are not getting the recommended care right now. So that engagement piece with your patients in your community, in your market is so vital. And the goal as we sort of move to the right is automating our care gap identification and patient notification. So we want to close the care gaps, and that's really going to happen with a comprehensive care coordination strategy, which we'll talk about in another slide or two. And then also automating your patient notification, whether it relates to scheduling or allowing communication between the patient and the provider. And then finally, we want to fully complement our EHR investment to make sure that we can aggregate the data across multiple systems. So, this is where ideally, you have the similar platform for the EHR on the inpatient side as you do on the outpatient side. We know that that's not always going to be the case, so we'll sort of talk about that moving forward as well as we transition here. So effectively targeting our patient population to help reduce risk. We want to really focus on patient activation, engagement, and empowerment. We need to have a plan for every patient. It's really essential to us being successful in any strategy, but particularly our ambulatory care strategy. And I think the picture that you see here of the iceberg really tells the story of sort of where we are right now, in that certainly what you can see above the waterline are your chronic patients with multiple comorbidities who are utilizing the vast majority of both the national resources and your respective systems resources as well. That is where our care coordination activities have really been focused, and appropriately so. But it's what we don't see that I think is really the opportunity for us and sort of simultaneously the concern. And then you see to the left of the slide, 67% of the patients who are catastrophic this year were not catastrophic last year. So the opportunity here is how do we minimize that number and the impact that has on our system. So, our goal as a hospital, as a health system, is to avoid the patients from becoming chronic. So, we want to shrink what we don't see underwater. So, we want to improve engagement. We want to prevent leakage from our system of our patients in the community that are accessing care. We want them to do that within our four walls. So I do think that, we want to make sure that the focus is on the whole population not just on that part of the population that we see above the waterline. And again, a plan for every patient is really essential to being successful in this endeavor. So care coordination, care transformation, sort of alluded to it as we've gotten to this point in regards to managing our patient population. The first question here is really the key question, is how do we establish and carry through our care coordination structure to ambulatory care? So most of the work, most of the focus on care coordination has really been put into the four walls of the hospital, into the inpatient side. Certainly some systems are far down the road of integrating both their inpatient and outpatient care coordination structures. Some folks are embarking on it now, and some folks are still in the planning stages of this piece. It is imperative that the care coordination umbrella is aligned between both the inpatient and the outpatient ambulatory care side. If our goal is to keep patients out of the hospital and to prevent readmissions, it is imperative that our physician clinics and our ambulatory care clinics are aware of how the care coordination strategies overlap from the hospital setting. So we want to make sure that we're aligning our nurse navigators, our care coordinators, or whatever nomenclature your hospital or health system are using, that there is overlay of these individuals with your physician offices. And then alignment and communication of the patient risk from the inpatient hospital to the ambulatory care clinics. I mean, it really comes down to communication. This slide could be called communication. Care coordination must flow consistently from inpatient to outpatient and follow the patients in the ambulatory care setting. And that alignment across the continuum of care coordination is really a key piece here of being successful in this endeavor. Ideally, technology is aligned as well, which I alluded to earlier, as it relates to having a similar EHR in both the inpatient and outpatient settings, but that's not always the case, and in some of your cases, that's just a barrier you can't afford to tackle right now financially. So that makes it even more important that the care coordination, care management structure of your organization is outside the four walls of your hospital into the outpatient and to the ambulatory care setting. So with that being said, I'm going to transition both the delivering to Stacy, my colleague, delivering more effective care, and then also managing cost and increasing effectiveness and efficiencies.
Great. Thank you, Jim. So now that you've figured out what your market looks like, you're ready to engage your patients and focus on the impact of the care that we deliver. So the question is, how are we doing today? And unfortunately, the answer is not so great. There's a lot of scary statistics here on this slide, and I'm not going to go through all of them, but I do want to point out a couple. And the first one is that the third leading cause of death in the U.S. is medical errors. And the second one I want to point out is by 2020, we're going to see the doubling of healthcare data, so more data to manage. Unfortunately, one of the most dangerous things we can do right now is go to the hospital. When we see physicians spending 6 or more hours interacting with the EMR outside of the clinic hours, that really is not leaving much time for them to keep up on new professional insights. So, it's not surprising that we see all this physician burnout. And, bottom line, these physicians are losing their personal touch. So what do we do about this? We really need to help change the landscape, and we need to do it in 2 ways. First, we need to focus on the physicians, and second, we need to focus on the patients. So on the physician side, just to kind of bottom line it, physicians need tools. They need tools with data to support confident and efficient decision-making where they can leverage evidence-based data to increase standardization. And by increasing that standardization, that's when we're going to see the reduction in those drug and treatment errors. On the patient side, we need to do a better job of educating the patients on the implications of a high-deductible health plan. As Wes mentioned earlier, deductibles have increased dramatically to where it's hitting the patient's pocketbook. So they just really need to better understand the importance of preventative care. And as part of that education we provide, we need to help change the mindset of the patient who thinks that the front door of the health system is the ED. And instead, we need them to better engage with their family doctor or their PCP and really steer them towards using those lower cost entry points like urgent care centers and physician offices. So speaking of cost, now that we've gone through the clinical piece and the market sizing, the next step is to really think about how do we run our healthcare organizations as a business and provide a margin so we can continue to provide that additional value to the patient. And you do this by managing costs and increasing operational efficiencies. You can be an organization that has the best clinical quality, but if you're doing it at a negative operating margin, this is surely not going to fly in the long run. It's definitely not sustainable. So on this next slide, I wanted to share with you some metrics to help illustrate the increasing gap in expense performance across the country, looking at top versus bottom performers. What we're seeing is across the board increases in expenses. So if you look at the chart on the right, the darker blue chart, we can see that there is a national average of 6% growth in total expenses. And then on the right, what I'm going to focus on is the labor component. Specifically, I'm going to look at labor expense per CMI adjusted discharge. And I'm going to share with you some data points that are not on this slide. But what we've done is we've mined our database, our ActionOI operational benchmarking database, and we found that the average annual cost difference between top quartile and bottom quartile performers on labor expense alone is roughly $38 million. The average annual labor expense is $140 million. So even if you're only able to make a 1% improvement on labor, that's nearly a $1.4 million opportunity to reinvest in your organization. Unfortunately, however, most hospitals are going in the opposite direction. And what we're seeing on this chart on the left here is, patients are getting sicker and the wages are increasing by 3 to 5% annually. So that's the national increase that we're seeing. In our database, though, in ActionOI, hospitals seem to be doing a little bit better. So when we looked at evaluating 2017 compared to 2018 data, these hospitals on average, rather than seeing the national growth of 3 to 5%, they actually saw a 0% growth for labor spend. But what was more interesting is that the top performers actually improved their expenses by 4.7%, or roughly $20 million. Pretty impressive. So how do we tackle this growing expense concern, particularly on the labor side? So when you think about operational and financial performance, we really need to focus on the entire health system and how it compares to other similar and or better performing organizations. So on the hospital side, we need to be able to drill down to the most granular level, looking at that department level, which is where you're going to have the greatest impact on organizational labor efficiency and cost effectiveness. And then on the ambulatory side, not only ambulatory care centers, but physician practice level. And ideally, we need to be able to drill into that data by specialty. In either case, when you think about the resource utilization, especially the labor expense, since that's your biggest spend, you need to be able to identify if your labor opportunities are due to cost of labor, labor efficiency, or both. And you need to be able to assess this information both quantitatively as well as qualitatively. So for example, on the quantitative side, we might think about what kind of things impact our cost of labor. Maybe we evaluate our skill mix. Do we have, a high percentage of management or professional staff? What if we have a high percent of overtime or contract labor? All of these things impact the cost of labor. And what are the things that you can do to potentially reduce that to still maintain the quality of the care? On the labor efficiency side, what we found is improving labor productivity not only can lead to decreased costs, but oftentimes higher utilization. And when you're able to increase that utilization, in many cases, we found that can also help you increase your revenue. And then finally, on the qualitative side, rather than focusing on similarities, we recommend focusing on operational differences and how those differences impact your resources. But more importantly, what can you do to improve upon those operational differences to become more productive and cost-effective and generally improve your outcomes? So with that, I'm going to turn it back over to Wes to wrap us up.
Thank you, Stacy, and thank you, Jim. So I appreciate everyone staying with us throughout this presentation. As we come back to the beginning of this first 4 key areas we want to focus in on, I want to rephrase them back to the group and say them backwards to forwards. So if the focus we've seen from this group and from Stacy's presentation there a moment ago was focusing on managing costs, increasing the efficiency of the healthcare we deliver, I think of that as the end result. That is actually delivering the care and doing so at a margin. And that is the final step. So taking it backwards, if that's the target many of you have, make sure you think upstream. upstream in terms of delivering effective care, number 3. If you're delivering high quality care without at a negative margin, again, no margin, no mission, you won't be open for long. But if you're delivering poor care but at a high margin, then the fact that you have a high margin doesn't matter. So again, focusing first on the margin at the end, but only after you have the ability to produce high quality care. And then if you think about 1 and 2, so managing the patient populations and optimizing the market strategy, it's empowering the patient, or realizing the patient has become empowered to make decisions in healthcare on their own, and understanding what you need to do to position yourself effectively to capture those patients to then deliver that high quality, effective care. So I suggest think about this backwards to forwards as well as forwards to backwards. We're seeing a big focus, and I'm looking at one of the questions that came in today about cost containment and the fact that that's been a top priority for decades. And this is, William, coming from you, but that the number of dollars that go up over time, what's different today? I'd say what's different today that we've heard in the market is, one, and it's a little bit of a complex answer, but one, we've seen an aligning, not an alignment, but an aligning, because we're not there yet, of incentives from contracts to deliver care in a value versus volume-based format. So thinking about how do we actually think about doing less will actually make you more money. That is a component of what we're seeing in the decrease in cost, or the focus on cost containment. The other piece to that, though, I'd say, is we are in a lot of conversations we have, especially with organizations that are operating 3, 4, 5% margins, is they're saying, hey, we've been fat and happy for years. We've had great payer mixes, and our patients have been well insured, and we've got whatever it might be, good margins, high quality delivery of care. But they see that on the horizon, these storm clouds are brewing, and they know that things will be changing, and they're not sure exactly what those will be. So I think there is a shift in our market toward sustainable cost reduction, because it is the one thing that you have most control over, and that will help you be prepared for an uncertain future. So with that, I'll thank the group for the co-presenters for presenting with us today. For those of you on the line who were able to join, thank you for your time, and we will now open it up to questions.
Great. Well, thank you, Wes, Stacy, and Jim, for such a fantastic presentation. We'll now go ahead and begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We will try to get through as many questions as we have time for. And it looks like the first question is from an audience member who asks, what are some of the most common hospital-based procedures that are transitioning to hospital or non-hospital ambulatory settings? And what are your thoughts on hospital or non-hospital ambulatory surgical centers?
This is Jim. I'll take this one. So some of the most common hospital-based procedures that are or have been transitioning are typically related to your more common orthopedic procedures. So we're seeing that, as well as your GI procedures as well. So colonoscopies, EGDs, those types of things. So more of your higher volume, more routinized procedures. So orthopedics and GI are the top of mind, sort of the two most common. As far as thoughts on hospital versus non-hospital ambulatory surgical centers, in some cases, in some of your markets, an ambulatory surgical center is a joint ventureship, or will be a joint ventureship with key physician groups in your market. So it is another opportunity as well for some physician alignment, some physician relationships as well. So one thing to keep in mind as well on the ambulatory surgical side, if you're looking at a new venture. So hopefully that answered the question. So thank you for that.
Of course, and thanks for sharing your thoughts on that. The next question is, what software tool relevancies, aside from the EMR, have a high relevance to achieve these strategies?
This is Wes. I'll take this one. I'd say data. Data is the easy way to answer the question. The challenge with data is that the common term we hear often now is that I'm data rich, insights poor. So what we're seeing in many of these, and if I translate this to value-based care, think about the value-based care penalties or incentives you're getting paid from CMS. And what's happening in this kind of reverse Robin Hood scheme is that those top performers in the industry are getting paid incentives from CMS that are being funded by those poor performers who are getting penalties from CMS. So if you're doing poorly today, you're going to be paying penalties that are going to the organizations that are performing better than you today. And so that makes it difficult to bridge that gap that Stacy identified in some of the costs we're seeing, for example, of expensive labor within healthcare. So the reason I go back to data and that example is that it's the EMR is great. What you're doing internally and the efforts most organizations have going on are wonderful. The challenge is that in the future, it's not about performing better than you did last year. It's about performing better than the market and improving relative to that market. It's the old adage of if you want to outrun a bear, you don't need to run faster than a bear. You just need to run faster than your friend next to you. And so we need to think about healthcare in that not absolute term anymore, but a value term, a relative term of performance. So all of this information and these changes we're trying to do, and change is always tough, is we need to be able to provide data-driven decision-making functionality or the ability to make data-driven decisions to the executives and to the providers. And so there are, I'm not going to name products or companies that do that, but there are many out in the industry who offer those sorts of data and analytics assets. So long way of going around to say, I think that data is key in succeeding in this world.
Great, thank you for pointing that out. The next question is about payer strategies, and this audience member says, can you advise on some strategies in negotiating outpatient procedures shifting from inpatient with commercial payers?
This is Jim. I'll take that question. Depending on the market, we've certainly seen some commercial payers that are actually driving this conversation, more so even than the providers, because they see it as an opportunity to provide a level of service at a lower sort of fixed cost. It also does provide a little bit of a potential foundational piece to looking at some more bundled type of procedures and bundled type of agreements with some of your commercial payers in your market. So that's a lot of what we're seeing. I think from the payer side, I think if you can demonstrate that you can provide this, same quality, same high level of quality at a price point that's, maybe a little bit more efficient, a little bit less than what it is in an inpatient hospital, you'll certainly have the payer's ears. And I think the opportunity then becomes, we view the ambulatory care strategy and growth as a potential market share growth for hospitals and health systems as well. So if you get that partnership with that key payer in your market, you may start seeing, patients coming from outside of your primary service area to utilize, your new facilities for those procedures. So I think the payers will be all ears if you can demonstrate that.
Wonderful. Thanks for elaborating on that. The next question is from an audience member who is asking just to hear your thoughts on price transparency in the ambulatory setting.
I'll take this one again, Wes.
I'll take this one. Okay, go ahead.
Go ahead. I'll piggyback on what you say. No, you go first, and I'll piggyback on it. Go ahead.
Okay, so what we've seen here in the price transparency, and for those of you who haven't been following the news on this, there's an executive order that came out last month focusing on improving transparency in pricing for patients. Largely is driven by our increasing costs and then also the high deductible health plans leaving patients unaware of what might be hitting their pocket. A couple things we've seen. One is how do we, and it's a moving target is the answer here, but how do we provide price? What does price mean in the ambulatory space? And it means different things from a payer or provider side. And so the first thing we can do, and we've seen organizations do this, is slap their CDM or charge prescription master on their website in hopes that's just a first step in transparency. The second thing, and we're seeing more of this, is understanding what's truly the patient obligation, because that's really where patients are going to be coming from. And what this gets to is price transparency will lead patients to the outpatient side because it will indicate or show that costs or prices in that setting tend to have lower costs for that patient. So that is a much more complex answer that requires looking at patients' deductibles, co-insurances, the plans they have, the met deductibles and co-insurance, and what might be left out of pocket, whether you're in or out of network. So what we're looking at, I think we're assuming might happen here at this point, and that's just an assumption, is that there'll be a middle ground found in which I can identify the prices, the average price for a procedure in a given market. And that might allow us to then have ambulatory centers or non-acute hospitals, let's say, post prices relative to that chart, the sheet, the average price we expect to see, and entice patients in there because they'll educate them on the actual price they're expected to pay. So I'll pause there to kick it over to Jim, but only to say that this is it's a moving target for sure.
I mean, I think Wes, your answer nailed it. I think the other piece, just of some recent news that came out last week, is just the announcement of some mandatory bundles as well, specific even to taking, for example, radiation oncology, which again is looking at an episodic payment, but also looking at providing that care over a 90-day interval at the lowest possible cost at high quality. So as you start to see the whole concept of mandatory coming back out from the federal government, it appears to be setting the stage for more and more of a move towards price transparency in your markets.
Great. Well, thank you, Wes and Jim, for both weighing in on that one. The next audience member asks, what strategies have you found to be successful as it relates to getting buy-in and alignment with contracted provider groups such as anesthesia or radiology?
Jim, you want to grab that one?
Sure. That's the $1 million question. I was on mute. I let out a little sigh when I heard that question. I mean, that is the challenge that a lot of times that you're facing, and I think that there's some strategies that have been effective in getting, for instance, anesthesia involved is really looking at what the potential volume and growth in the volume in their cases is moving forward. So I think that has, that use of data, again, we go back to locally precise forecasting and looking at what the current trajectory and growth potential is in your market for specific service lines. That specific data has been really successful in helping some health systems get some contracted physician groups, namely anesthesia, who are in many cases not employed by the hospital or health system, to participate, in some transition of procedures to an ambulatory care setting.
Great, thank you for touching on that.
This is Wes. I was reading through a couple of these, and I wanted to address an answer that might cover a few. And this is really looking at cost and cost centers. Really, what are the driving cost centers of an organization? There was a big focus, right, in the poll around which priority is top, and the cost containment was certainly one that jumped out. So within cost centers, and the question is, beyond labor and HR, what's the next cost center, right? Where is the next area where we're losing a lot of money? And it's hard to say that on a market industry-wide approach, but what we are seeing is that one of the drivers of cost forecasted by ourselves and a number of other research entities looks at medical supply costs and drug expenses as being a primary driver of healthcare costs moving forward. We'll see what happens in Washington around the pharmaceutical piece. It's an area that we don't get into much on our side anyways. But if we have a way to get our arms around the pharmaceutical piece, we are still seeing physician preference items and supply costs overall being a main driver for what we can call a cost, or contributing to a negative margin, let's say. And then there's one other component I want to add in here, and then a lot of the questions are related to how do we engage physicians and how do we align the incentives, and they go hand in hand, right? So one assumption within engaging physicians in a retail or ambulatory setting is or digital healthcare, for that matter, is decreasing or devaluing the care that we deliver to patients, and it's really a way in which we describe it more than anything else. So if we are delivering care in an ambulatory, retail, or telehealth setting, it's not devaluing the care we're providing. It's telling the patient we're willing to meet them where they are. We're not requiring them to come to the hospital. We are deploying our services into the market to meet the needs of that market. And that, I think, is a key component as we think about this. It's that we need to change as providers. Within the Affordable Care Act, one thing, and maybe the one area that has been really, really successful outside of pharmaceuticals, is the payers. The payers have been doing great relative to providers. Providers, and then physicians in particular, tend to get stuck in the end of saying, oh, okay, we've decided this is the new path, go ahead, and everything's going to end up on you. And then this is going to cover another question where a lot of that focus, or the things that run down to the provider, healthcare executives and payers say, well, the physician can take care of it. And so one thing we need to do is we need to provide those physicians with tools to extract data out of the EMR using AI, using technologies that allow us to mine the EMR for relevant data and present that to that physician in a way in which they can review that data with their patient, and they're not spending all of the time hunting and pecking and searching in EMR. Allow them to pick their eyes up and reconnect with that patient. That's going to increase the value of the interaction, whether it's in a hospital or a retail environment. It's going to get the patient or the provider out of that EMR, connect with the patient, decrease the chance for burnout, and it will engage the patient in their healthcare, therefore improving outcomes and decreasing costs. So I wanted to cover a couple there. Mackenzie, I'll turn it back over to you.
Wonderful. Thank you so much. Before we go ahead and end today's presentation, I'd love to just turn the floor over to you, Wes, Stacy, and Jim, one last time to share any final thoughts that you might have.
This is Wes. I'll share a brief one, and that is there are a number of additional questions we have in the chat box here. We will diligently go through those and ensure that we can answer the questions that have been asked to us. So I wanted to thank you for your time, and hopefully this was a good use of everyone's time, given the questions that have been posed. Either we created more confusion or provided some value. So hopefully it's the value, or hopefully it's the latter.
This is Jim, Wes. I hope so as well. I think I just wanted to interject. This is a topic that, that has obviously gotten a lot of attention, I think, by the number of attendees on today's call is great. And as each of the systems are looking at your ambulatory care strategy, as Wes said, hopefully, sort of our 4 strategic imperatives are helpful in helping you to sort of organize your strategy moving forward. But we really appreciate the questions, and like Wes said, there are many more questions than we can answer given the allotted time, but appreciate everyone coming out for today's call. So thank you.
And I'll just wrap up by saying, again, thanks everybody. On this last slide, we've put our contact information, so if you have additional questions that come up after you've had a chance to digest this material, certainly reach out to us, and we'll be happy to get back to you just as soon as possible. So thanks again, everybody.
Great, and thank you, Wes, Stacy, and Jim, for such an excellent presentation, and to IBM Watson Health for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.